Hello guys, hope you are doing good. This is Dr. Krishna Kumar here. Now the NEET-PG 23 is over. I hope you guys observed the common trend that is keep on repeating. What is the trend, sir? See guys, there is a very well known fact. You know, I know. But what examiner is expecting? They are changing that fact into a clinical scenario based question or a graph or a picture. Rather than asking directly, they are doing it in an indirect way in the form of a clinical scenario or images or graphs for that matter. This trend is definitely going to get repeated. Whatever may be the exam, NEET-PG exam or next exam, this is going to be the common theme. So if you understand this common theme, whatever may be the exam pattern, your preparation is similar. What is that? The known fact, the answer which is the known fact, is going to get converted into either a clinical scenario or a picture or a graph. That's all. Now in physiology, NEET-PG 23, what we observed is there are a lot of graphs. So many graphs came. Concepts we know, but they changed that into a form of a graph. Many we discussed already in our video lectures. Now here we are going to see what are the questions asked in physiology section. So let's move into the question section. Whenever I put a question, just pause it and you yourself trying to answer. Then I will show you the answer and a bit of an explanation for that. So with that idea, we'll move into the question. One of the well-known chronic repeat area, both for Anaesthesia and NEET-PG action potentials. And this time the beauty is both nerve action potential and cardiac action potential. They asked the question. Very similar question. Identify the true statement regarding myocardial action potential curve. This is the myocardial action potential curve. There are a lot of options here. This phase 2 is due to calcium. Phase 4, is it due to opening of sodium or closing of potassium channel? Or phase 0 is due to closure of sodium channel? Or phase 3 is due to sodium potassium ATPase? What do you think is the answer, guys? So these type of questions, you should never ever make a mistake. You have to be crystal clear in these concepts. Obviously, the answer for the question is very simple. It is A. The plateau phase, that is phase 2, is because of calcium channel. A very important discussion. Now look into this graph, guys. This is the typical ventricular action potential. Now, what are the important phases of this ventricular action potential? We have something called as phase 0. Where is that phase 0, guys? This is phase 0. Then we have phase 1, this classical phase 2, which is asked here. Then we have phase 3, and finally we have phase 4. What is this phase 0, sir? This phase 0 we call as early depolarization. All depolarization we all know is basically because of sodium ions coming inside. So the reason for this early depolarization is sodium influx. Very simple. Then we have phase 1, which is called as early repolarization. Repolarization is because of potassium ions moving out. So during this early repolarization, remember potassium ions moving out. An important point, this important potassium channels responsible for this phase is called as, remember guys, transient outward potassium channels. Early repolarization, potassium moving out, transient outward potassium current channels. This same potassium ions still keep on moving out to balance that calcium ions are coming inside. And this type of calcium current is exclusively because of a long-lasting calcium current. This was a familiar question asked 2 years before in INI-CET. Plateau phases because of long-lasting calcium channels. Now, they convert that into a picture-based MCQ. A known fact is converted into a graph here. That's all. At one particular point, remember guys, this calcium channel closes. Remember, for plateau phase, it is potassium moving out that is balanced by calcium that is coming inside. This calcium current is L-type calcium current. Phase 2 plateau is because of L-type calcium current. Potassium moving out is balanced by L-type calcium current coming inside. Then we have this phase 3. It is also repolarization, but it is happening late repolarization. The only ion that still keeps on moving out is potassium. So the answer for this is potassium ions moving out, potassium efflux. What we have seen so far, phase 0, early depolarization, sodium influx. Phase 1, early repolarization, potassium efflux, transient outward potassium currents. Then we have phase 2, plateau, potassium moving out is balanced by L-type calcium current coming inside. Then we have phase 3, late repolarization, where potassium ions are still moving out. The name of this channel is, remember guys, delayed rectifier potassium channels. For late repolarization, potassium moving out is because of delayed rectifier potassium channel. Finally, we have phase 4, that is reaching the resting membrane potential back again. What is the ventricular resting membrane potential? Minus 90 millivolt. How to reach this? During depolarization, sodium ions are coming inside. During repolarization, potassium ions are moving out. This is not a normal state for any cell. Just hold the hand of this potassium and take them back inside. Just immediately, fastly move back all the sodium ion outside. Now to reach the resting membrane potential back again, sodium ions are thrown out and potassium ions are brought back inside with the help of our very well known sodium potassium pump. That's all. There are phases 0, 1, 2, 3 and 4. We now know the ion channels responsible for these phases. Remember guys, this will surely repeat. Just make yourself very clear which ions play a role in which important phase. Now it is about phase 2. The question, it is because of calcium currents. We'll go back to the question. Remember, phase 2 is because of calcium currents. Which particular type of calcium currents are? L-type calcium channel. The answer for the plateau phase, it is calcium. L-type, the answer is A here. We have had an important discussion. Now let's move to the next question, which is also a graph-based question. Very familiar. Now they asked about nerve action potential curve. A, B, C, D, E. These points are there. They are telling B to D is refractory period. Threshold is A. At point E, the nerve is more excitable. Point B to D is due to opening of sodium and potassium closure. What do you think is the answer? I'll show you the answer now. We will have a detailed discussion. From point B to D is refractory period. Why, sir? Look here very carefully. Now, what is this point A, sir, in this graph? A is the resting membrane potential. For nerve, it is minus 70 millivolt. This minus 70 have to become minus 55 millivolt for action potential to fire. What is this value, sir? This value is considered to be our threshold. So this point B is threshold, or what I told you, action potential will fire. That is why it is also called as firing level. Minus 55 is threshold or firing level. Then after this, we will have depolarization. Yes, simple. Then we will have repolarization. Yes. And finally, we have what is this E here, sir? This is our hyperpolarization. Very important phases. We all know this. Threshold have to be reached. That is our firing level. Action potential will fire. We will have depolarization, repolarization, and hyperpolarization. Now look very carefully. During this hyperpolarization, the RMP is going more negative. It can usually go up to minus 90 millivolt. During hyperpolarization or point E, this nerve is least excitable. Why, sir? At point E, it is least excitable because from minus 70 reaching minus 55 is easy. From minus 70 reaching minus 55 is easy. Remember, from minus 90 to go to the threshold value of minus 55 is obviously difficult. You will agree? From minus 90 going to minus 55 is difficult. That is why it is least excitable. Now, most important concept here. From this point of firing level, look very carefully, guys. Till the initial third of repolarization. From firing level to the point of initial third of repolarization, we have something called as absolute refractory period. From this initial third of repolarization till the end of action potential, what we call is relative refractory period. So the answer is very simple. From point B to D. From point B to D, obviously it is our what refractory period? Absolute refractory period. This absolute refractory period concept, remember guys, this is the first stimulus I'm giving. In response to that, we are getting an action potential. Suppose if I give the second stimulus here during absolute refractory period, this nerve will not get excited. During absolute refractory period, if you give the second stimulus, this nerve will not respond. Why? It is because of inactivation of which important channel? Sodium channels that are responsible for depolarization. They are in an absolute inactivation state during absolute refractory period. If you give the second stimulus during absolute refractory period, you will not get another action potential. That nerve will not respond. Then what about relative refractory period, sir? Look very carefully. During this relative refractory period, if you give the second stimulus, this second stimulus have to be supramaximal. If it is supramaximal, you will get a response possible in the form of another action potential. From threshold till 1/3 of repolarization, absolute refractory period. If you give second stimulus here, the nerve will not respond because of inactivation of sodium channels. But during relative refractory period, if you give a stimulus and that stimulus should be supramaximal, very high threshold stimulus. If you give that, that nerve will respond. That's the difference between absolute refractory period and relative refractory period. Their point is important. From firing level to the first 1/3, absolute. From this 1/3 till the end of action potential, relative refractory period. Now, let's go back into the question here. From point B, obviously, till D, the initial third of repolarization, it is refractory period. True. That's why we are choosing that answer. Option A is the answer. Now, we have the discussion. Next question. Identify the type of transport across cell membrane. Another important fact. What is the fact, sir? We all know facilitated diffusion. It requires a carrier protein. Now, I will not ask you directly, guys. I will show you that in the form of a picture. Whether you will be able to think and answer correctly, that is the exact mindset of our examiner. It will be there for all the examiners in future also. Fact will be converted into a clinical scenario or image or a graph. Now, very simple. The answer is facilitated diffusion. I'm seeing a carrier protein. But what is the concept? Remember, guys, this facilitated diffusion is a form of a passive transport. That means there is no need for energy sources in the form of ATP. But what is most important, sir? C square. What is the C square? 1C, second C. The first C is there is something, a requirement in the form of a concentration gradient. The second C is in the form of a carrier protein. Concentration gradient means from high concentration, it will move into low concentration. In extracellular fluid, the concentration is high. In intracellular fluid, the concentration is low. This substance will now move with the help of a carrier protein. There is no need for ATP. You need only a carrier protein. What is this passive transport process? Facilitated diffusion. No need of ATP. That's why we call this as passive. Now, this type of carrier proteins are important for two substances. First, exclusively is our glucose. Never forget for your life. Remember this point. Glucose needs a carrier protein facilitated diffusion, and that is our glucose transporter GLUT. G-L-U-T. GLUT is the facilitated diffusion carrier protein for glucose. Remember this GLUT. Remember about glutes like you. Remember our national anthem, Jana Gana Mana. Never forget for lifetime. Definitely question will come. Every single exam question will come from glucose transporters. The second important carrier protein, obviously remember, aquaporins. Very important for water transport. So facilitated diffusion, when you see a carrier protein, choose facilitated diffusion. High concentration to low concentration substance will move through this carrier protein. For example, GLUT for glucose, no need of ATP, it's a passive process. Simple. I think 10 out of 10 students, everyone who saw this question would have definitely answered this question correctly. So who made a mistake, please don't make a mistake again in this question. It's a chronic repeat question. Next, identify the marked region in the spirometry graph. Another very familiar question. Yeah, this is the point. This point is marked. What is this? Yes, obviously it is our functional residual capacity. Now let's look into this graph now. Very simple graph. I'm sitting relaxedly and talking to you guys. You are simply listening to this class. We all need just a 500 ml of air moving in and out of our lung now. What is this volume? Tidal volume. Simply sitting, relaxedly listening to the lecture. But if I ask all of you guys to stand up and jump, yes, everyone now, stand up and jump. If you stand up and jump, this 500 ml is not sufficient. You need a reserve for inspiration. We have inspiratory reserve volume. You also need a reserve for expiration, expiratory reserve volume. The inspiratory reserve volume is usually around 2 to 3 liters. The expiratory reserve volume is usually around 1.3 liters. We are doing maximum possible inspiration and expiration. Remember, this is the point of maximum possible expiration. Even at the end of maximal expiration, still some volume of air left. You cannot throw that air out. It remains as a residue inside our lung. That is our residual volume, which is usually around 1.2 liters. Expiratory reserve is 1.3, residual volume is 1.2. This we have discussed every single time in our video lectures. Now, the most important capacity, remember guys, there is something called as functional residual capacity, which is the combination of expiratory reserve volume plus residual volume. So, how much it comes? 1.3 plus 1.2 equals 2.5 liters. What are the possible MCQs from this functional residual capacity? Remember guys, we know the total lung capacity is 5 liters. In this 5 liters, compare how much is 2.5 liters? Exactly half. That means F or C is 50% of our total lung capacity. This is considered to be the midpoint, the halfway. In the halfway of the entire total lung capacity, we get our F or C. This half point, midway point, is also called as equilibrium point. That is why you also call this as equilibrium volume. F or C, 50% of total lung capacity, also called as equilibrium volume. Now, extremely important concept. Now, I will hear it from you. Tell me guys, tell the answer. What is the volume of air that is left in the lung at the end of maximal expiration? Maximal expiration. What is that volume? Tell me. Yes, you are correct. Residual volume. But what about F or C, sir? it is the volume of air that is left. Remember, this entire point is our FRC. And this is the end of our normal expiration. That means FRC is the volume of air that is left in the lung at the end of normal expiration. Maximal expiration, residual volume. At the end of normal expiration, what is the volume of air that is left in the lung? Functional residual capacity, which is 2.5 liter. It was asked many times before. Be familiar with these concepts. Now, look into the graph. The volume of air that is left in the lung at the end of normal expiration. What I told now, as a matter of fact, they asked 3 years before in a NEET-PG exam. Volume of air left after normal expiration is FRC. Now, why to ask directly like this? I will show this guy a graph. Whether he will be able to think and answer correctly, that is what they did now. They will do like this frequently hereafter. You have to keep on thinking. I hope you will definitely think correctly and answer them. Improve your thinking ability. That will save you for all the future exams. Now, next question. Preterm baby delivered at 28 weeks. Preterm. Which of the following is true about surface tension and compliance? Preterm babies, definitely the surfactant will be deficient. To understand this concept, we'll come back to the answer. Now listen to this. Now, consider this is our alveoli. Okay guys, this alveoli is at rest. Now, follow my instruction carefully. I'm going to ask every single one who is watching this video a small task. Do it for me guys. At my command, all of you take a deep inspiration now. Take a deep inspiration. What will happen to this alveoli? It will exactly become like this. This is during deep inspiration. This alveoli is undergoing something that is called as distension. What is this distension, sir? The other name, the technical term, the fancy term I must say for this is compliance. Compliance is none other but the distensibility, distension capability of our alveoli. But this distension will not happen just like that. Remember our great Newton. What he told, Newton's third law. For every action, there is equal and opposite reaction. This distension is the action. We all performed an action, right guys? Yes, this compliance is the action. To oppose this, remember, to oppose this according to our Newton's third law, this alveoli is usually lined by a molecule of water. Simple, yes. This water is at the surface. Yes, sir, yes, sir, yes, sir, we are seeing. This surface sitting water is going to exert a force that is called a surface tension force. This surface tension is a force that needs to be reckoned with. You need to tackle this force, a huge force. What is this force, sir? Surface tension forces. Obviously, if you want to have a good distension, your alveoli should be distended with air for all healthy individuals. So if you want to have a good distension, you need to oppose this surface tension with the help of a very important chemical, that is our surfactant, which is known to reduce this surface tension forces, thereby increase compliance. Surfactant is the chemical that decreases surface tension forces. It is very helpful. It makes us survive. That survival substance is surfactant by reducing the surface tension. This is the first force. The second important force is also there. Remember guys, lung spring. That's all. Lung spring. It is an elastic structure. We call this as elastic recoil. They don't make things simple. They will complicate it. They call this elastic recoil as something called as elastance. Take home message. Compliance is inversely related with the surface tension according to Newton's third law. Compliance is inversely related with elastance according to Newton's third law. If you understand the simple basic what we learned in our school, you can tackle this MCQ. So surfactant is deficient in a preterm baby. So the surface tension will definitely increase, compliance will decrease. It is not rocket science at all. When surface tension increases, compliance will definitely decreases because both are opposing forces. With this idea, let's look into the question. Preterm baby, surfactant deficiency, obviously. Surface tension will increase, compliance will decrease. Eventually, that alveoli will collapse, which we don't want. We usually treat these individuals, treat these preterm babies with the surfactant. There are very good treatment available now. But remember, we won't let the alveoli to collapse. We have treatment capabilities these days. But as a concept-wise, remember, surface tension increases, compliance decreases in this preterm baby. Yes. Now, the next question. Identify the respective substances in the clearance graph. Another very important question where you should think very carefully. We have discussed these concepts in lecture. What is A, what is B, what is C, what is D? Any idea? You answered it correctly? Yes. Big round of applause to you. Whoever did not answer the question correctly, for you guys, I am there to help you. Where it went wrong, why it went wrong, what you missed. Let's find out. We'll come back to the answer now. Look here, guys. Bowman's space, proximal tubule, distal tubule, urine. We are talking about tubules and the fluid in it, which is going to eventually come out as urine. If you understand, just nod your head. We are talking about the tubules and the fluid there. So it is tubular fluid. What is the important parameter we are interested? We are concentrated on the concentration. Tubular fluid concentration. Now look into this important, guys. See, this C for constant. There are some people we call as constant in our lives. Whatever happens in the external world, they will be always there for us. Constants. Remember, C for constant. Whatever happens in proximal tubule, whatever happens in distal tubule, nothing will disturb me because I am neither getting reabsorbed nor I am secreted. No reabsorption, no secretion. I will remain constant. And that credit goes to our gold standard substance inulin. He's a constant. Nothing will perturb him, nothing will disturb him. No reabsorption, no secretion. The C is inulin. Now look at this guy, D. In the tubular fluid, his concentration increased. That means somebody is actively secreting him. You understand now? Now, why the substance's concentration is increasing in the tubular fluid? You are giving something into tubular fluid, but you are getting more than that because he is getting secreted. Who is that guy? Para-aminohippuric acid. Not only him, one more guy. D also shoots for this guy. Remember, future MCQ, he is none other but our creatinine who will have secretion. Para-aminohippuric acid and creatinine. And this is the privileged guy. Our body needs more of him. A, he is getting completely reabsorbed. 100% reabsorbed. That is why his concentration in the tubular fluid definitely decreases. And this guy A is our glucose. Who is this guy? B, he is also getting reabsorbed, but around 80% reabsorption. And this guy is definitely our bicarbonate ion. When you see this question, what you should think? We are talking about tubular fluid concentration. If the concentration is constant, he is inulin. If the concentration decreases, completely decreases, 100% reabsorption, all are reabsorbed, glucose, 80% reabsorption, bicarbonate. But if the tubular fluid concentration increases, if it is increasing means they are undergoing secretion, you have para-aminohippuric acid and creatinine. It is about the tubular fluid and the concentration of substances in it. Now look into the question, guys. Obviously, A is glucose, B is bicarb, C is the constant we all have, inulin, and D is para-aminohippuric acid. All also remember creatinine. Very important graph, surely it will repeat. We had the discussion. Now the next question, guys. It is about potassium levels which are elevated. 5 is the cutoff point, 5 milliequivalents. Here it is elevated 5.5. On an emotional note, it's a very serious problem we need to tackle immediately. It's an emergency state. So rather than seeing this as an MCQ, remember guys, you are having a very important job here. Whenever you see hyperkalemia, please be very careful. Wherever you are working, hyperkalemia is a serious medical emergency state. You need to tackle this. You need to have the skills to tackle this. Rhabdomyolysis, for example, lot of things can lead to hyperkalemia. A person came to hospital after RTI. He had severe muscle injury, potassium leakage, hyperkalemia. What would happen to RMP? So starting from basics, they are asking about the basic concept, what will happen to the resting membrane potential. It becomes more positive, obviously. Look very carefully, guys. Consider this cell now. We all know the privileged potassium, I always say. Very safe, always inside, it is more. There are a lot of potassium ions inside. Usually on the extracellular fluid, potassium ions are less. Now, what is the situation they are giving? Remember, it is hyperkalemia. Normally, potassium ions tend to move from high concentration to low concentration. This is the basis for our resting membrane potential. The only ion which can modulate resting membrane potential is potassium ions, because the cause for resting membrane potential is potassium ions. It normally moves from high concentration to low concentration. Now there is a situation, our homeostasis is disturbed. When homeostasis is there, everything is constant, no problem at all. Here, something is disturbing our homeostasis. There is hyperkalemia. That means there are a lot of potassium ions accumulating outside. This diffusion will be hampered. You can understand. There won't be much diffusion because there is no concentration gradient. Outside, potassium levels are rising. The normal diffusion is disturbed or hampered. All the potassium will accumulate inside. Remember, guys, for example, the resting membrane potential of this cell, let's consider minus 90 millivolt. Potassium is accumulating now because of hyperkalemia. Potassium is positive. The inside becomes more positive. Simple logic. Potassium is positive. I translated that to the inside becomes more positive. We don't stop there. Minus 90, accumulation of more positive ions. This minus 90, if it gets reduced to minus 55 millivolt, that means we are reaching our threshold. The inside becomes more positive, minus 90 becomes minus 55, threshold means action potential will fire. If this process keeps on getting repeated, more action potentials. If this is the cardiac cell, obviously, they are more prone for arrhythmias. So hyperkalemia, potassium accumulating inside becomes more positive. Accumulation of positive charges, minus 90 can quickly become minus 55. Threshold, action potential fires. Another action potential. Arrhythmias. Cardiac arrhythmias are very common in hyperkalemia. So the basic physiology concept they asked here. We now know the clear-cut answer. The inside becomes more positive in hyperkalemia. The opposite is true for hypokalemia. Here it is hyperkalemia, the inside becomes more positive. Simple. We know the logic now, very important. Next. Penetrating cervical neck trauma, piercing the lateral aspect. Circle this lateral aspect. This is the brand new question they asked here. Dorsal or posterior column tract. Which of the following finding is seen? Let's understand this with the help of a diagram. I told you it's a brand new question. Again, the application of a basic fact. I will tell you that basic fact, guys. We have dorsal column or posterior column. We have anterolateral spinothalamic tract. This dorsal column remains ipsilateral in spinal cord. This anterolateral is contralateral. Dorsal column is ipsilateral. This is the fact we all know. Next fact. This dorsal column is for proprioception, is for fine touch, is for vibration. This anterolateral is mainly for pain and temperature. These are all the facts we all know. Now, one more important fact. This dorsal column has got two important subdivisions. We have cuneatus and gracilis. Remember, guys, walk gracefully. That is the mnemonic. So we walk gracefully. Walk lower limb gracilis. Remember, cuneatus, underline this eat upper limb. Dorsal column sensation from the upper limb is through cuneatus. Now, which is lateral, which is medial? This midline is our medial part. The other side is our lateral part. Remember, we have the posterior column or dorsal column shown here. Then we have the anterolateral pathway also shown here. Now look very carefully, guys. Our gracilis is there, cuneatus is there. This gracilis is medial, we are seeing. This cuneatus is lateral. Suppose if you have a penetrating injury in the lateral side, obviously your cuneatus will be affected. If the cuneatus is affected, the upper limb dorsal column senses will be affected. In spinal cord, in the dorsal column, gracilis is medial, cuneatus is lateral. With this idea, look into the question again. So dorsal column means definitely ipsilateral it will be lost. Lateral side means who is going to get affected? Cuneatus. That means upper limb, arm, upper limb. Proprioception, dorsal column sense ipsilateral, dorsal column. So the fact beautifully converted into a very important concept. Remember, among dorsal column, gracilis is medial, cuneatus is lateral. Depending upon the injury spot, if it is lateral, cuneatus will be affected from the upper limb. Eat, cuneatus, eat, upper limb. So obviously, the upper limb dorsal column senses ipsilateral side, it will be affected. So now you know the concept now. Very important diagram. Just pause for a moment and understand this. Now the question, guys. A laborer becomes unconscious and is brought to the emergency room with a temperature of 105 degree Fahrenheit and decreased skin turgor. Which is or what is not seen in the patient? I will again remind you, guys, last 2 years, the focus is hugely on environmental physiology and environmental hazards. Every year question is coming from these environmental aspects. Please be thorough with it. Revise 3 times anything concerned with environmental physiology or environmental hazards. This question is about a very, very, very serious medical emergency, that is our heat stroke. The answer for the question, obviously, sweating will not be seen. What is this clinical state, sir? Extremely important concept. Remember, whenever we talk about heat stroke, it is a serious one out of all the heat illnesses, and it is a medical emergency. You need to attend to it immediately. Heat stroke. Classically, you think of heat stroke when someone working in the hot environment fall down unconscious and his core temperature more than 40.5 degree Celsius. Core temperature more than 40.5 degrees Celsius. He is unconscious. He will have increase in respiratory rate. He will definitely have increase in pulse rate. His skin will be hot, red. Tachycardia, tachypnea, hot, red skin, coma. Remember, very important point and extremely important concept. In this state, the thermoregulatory mechanisms are totally lost. That means the normal physiological thermoregulatory mechanism is not intact. That is why classically there is no sweating in this group of individuals. You may get tachycardia, you may get tachypnea, hot red skin, unconscious state, coma, but sweating will be classically absent. The thermoregulatory mechanisms are not intact, they are lost. Most important point, extremely important point, there are two important forms of this heat stroke. The first one is the classic form. You see mainly in the old age individuals and also in the one suffering from any chronic diseases. The second type of heat stroke is called as the exertional, typically seen in the young age individuals, athletes, soldiers who are standing in the hot sun, any young individual working under the hot environment. What you see is the exertional pattern. Two forms, the classical form and the exertional form. You see heat stroke, sweating will be classically absent. The most important aspect, remember guys, treatment. Quickly move them into a cool place. Give them a cold water bath. Give them cold sponging, evaporative cooling, all these things you can try in them. Cold place, move them quickly. Cold water bath. Extremely important, they are more prone for arrhythmias. And this arrhythmias spontaneously resolve whenever you give the treatment cold maneuvers. Remember, arrhythmias are extremely common in them, but this arrhythmia will quickly resolve, spontaneously resolve when you do the cold treatment maneuvers. And finally, extremely important, give them fluid replacement. They are extremely more prone for hypotension, loss of fluid. Hypotension will be there in them. To tackle that, you need to give fluid replacement. And finally, most important point, they are also more prone for hypoglycemia, which is usually treated with glucose infusion. Remember guys, what I told you, it's a serious medical emergency. Move them to a cold place, cold water bath, evaporative cooling, all this you can try. They are more prone for arrhythmia, but don't fear. If you start the treatment maneuvers, cold water bath, this arrhythmia will resolve spontaneously. Fluid replacement is of utmost importance because they will have hypotension. You need to replace fluid and salt. And finally, they are also more prone for hypoglycemia. They will have hypoglycemia. Treat them with glucose. Heat stroke is a medical emergency. So please do revise about the environmental illnesses, environmental physiology, very high yield. Now look into this question, guys. This individual is unconscious. His core temperature is elevated. Definitely it is about heat stroke. Tachypnea will be there. Hypotension will be there. Red hot skin will be there. But sweating will not be there. Thermoregulatory mechanisms are not intact. They are lost. That is why sweating is not there. So if you look into this NEET-PG physiology questions, that common trend we are keep on observing. It is about the repeat topic, guys. Questions are definitely coming from the repeat topics except one or two new questions. And make yourself ready. You know fact. You have the factual information. You remember the concept, but they will convert them into a clinical scenario or image or a graph. So be ready for that. Hope you guys did the exam well. And for those who didn't get through, remember guys, this is not the end. Keep on trying. Always keep on trying. So never ever quit. Keep on trying, guys. One day you will definitely succeed. My heartiest wishes are always there for you guys. Good luck and best wishes. Thank you.